Hi everybody, welcome to my channel. I'm Stacy. If you're new here, welcome in. If you're coming back, I'm glad to have you. Let's talk about wound care. I love wound care. Let's talk about my shirt. It says I'm that nurse. It was a gift for Nurse Week, and a manager gave it to us. Well, a director gave it to us and directed us not to wear it at work. But I don't advertise that I'm a nurse generally out in public unless it pertains directly to, for example, I had to get a blood draw this week for insurance to get my insurance deductible down for not being a smoker. Go me. So let's talk about wounds. In hospice, which is where I work, we'll focus on that. We are looking more at comfort than anticipating the healing of a wound. Now, that's not to say that we don't love to see wounds improve in hospice, because we love to see our wounds heal and improve. It does give someone such a better quality of life if they are not experiencing pain from a wound on top of everything else, and drainage and odor and things like that that happen with wounds. The thing is, a pressure ulcer can develop in 2 to 6 hours. And there may be newer documentation than that it can develop sooner, but we're talking about a stage 4. We're talking about a serious stage 4. If a person is compromised nutritionally and their skin is compromised and they are bedbound and they are not able to move, they are at so much more risk to break down in a serious way. If I lay on my bottom for 2 to 6 hours, maybe I'll get a red spot. But probably because I'm drinking water, because I'm eating food, and because I'm able to move around, I am not going to develop the same type of wound that someone who is compromised will develop. Compromised with their disease process, hydration is so important in our life. You know, we never drink enough water, most of us. And sometimes, of course, you can drink too much, but that is rare. It's rare that I see anybody drinking too much water, unless they're on dialysis. I digress. When a person is compromised, they are at so much more risk to break down. Once they break down and that skin barrier is broken, now they're not just having a break in their skin, they're at risk for infection, and it can become septic. It can get into their system and it can lead to death. That is a fact. If a person gets a bad enough wound and it's in a place, say, where feces or urine is coming into contact with it, there's also bacteria that's coming into contact. Anytime we get a break in our skin, we're at risk for bacteria to get in. Our skin is a protectant. It's our protection. It keeps bacteria out, and it helps us to keep everything in, right? We don't want a break in our skin when we can avoid it. So wounds that we're looking at for pressure is when you're not able to move and you're sitting on one area, or one area is sitting. Usually it's a bony area. But you would be surprised where you can get a pressure ulcer. You can get pressure ulcers on the backs of your ears. This is cartilage too, so it doesn't heal as fast as something that has a little bit more circulation. You can get pressure on the back of your head, on your heels, on your ankles, on the kneecaps, anywhere. If you're laying on your side too long, the key is you need to change positions. If a person is compromised and they are unable to move themselves, they are unable to take in their own food, then it becomes our responsibility as caregivers and healthcare workers to provide that care and to make sure that these things don't happen. In a home care setting, CNAs and nurses are coming, a maximum an hour at a time. Sometimes CNAs are coming 5 times a week. Sometimes nurses are coming 5 times a week, but that hour is really all that we're there. So the biggest key there is education, education, education. It is so important that we're teaching our families how to turn and reposition their loved one. A 10-degree change in position relieves some of that pressure. Also, pressure relieving mattresses. That's expensive, but it's necessary when a person is not able to turn themselves, right? They need something to help them relieve some of that pressure that they cannot relieve themselves. And sometimes family members are also compromised and unable to provide the level of care that a person would benefit from in their home. And that's where your social worker comes in, because they can find caregivers and all those other things. But the biggest thing I want you to take away from that is that in a home care setting, it is so important that we educate our families about hydration, nutrition, about turning and repositioning, and about keeping the area clean and dry. Once we have a break in the skin in the hospice setting, we are looking at, is this a superficial wound? Is this a deep wound that has necrotic tissue that we need to get rid of? Because a wound cannot begin to heal if it has necrosis. Now, I have worked for hospice companies where we actually have a wound nurse that comes in and will debride the wounds or find, a solution for that. In nursing homes where we go into their home, some nursing facilities have a wound doctor that will debride the wound, and sometimes that adds a little layer of healing as well when you're getting rid of that necrotic tissue. As nurses in hospice, generally, as home care providers, we're not debriding wounds with sharp instruments. We're not cutting things off. We're not doing any of that unless we're certified to do those sorts of things. And then it becomes, is your company policy to debride wounds? If a wound has a hard layer of necrotic tissue, we're not disturbing it. We're leaving it alone, especially in people who are diabetic and people who are compromised. If you open that and take that layer of protection, that dead skin looks terrible. But if it's closed and it's not looking infected and it's not getting bigger and it's not changing, we just watch it and we relieve pressure. It's so important to teach the value of relieving pressure. I could talk about wounds all day, and maybe this is just letting me know that I still love it so much. The thing about wounds is it's come a long way in what we use to provide wound care. Some of the oldies but goodies are still around. We use, I'm sure I'm not pronouncing this right. I've always heard it called Dakins or Dakins. It is one of those things that you're going to use in a palliative hospice situation, especially when there's a lot of odor in a wound. We have things like silver that we can put in wounds that help kill bacteria. And bacteria is really what's causing the odor. Dead skin and dead tissue and bacteria are what is leading to the odors that we smell in wounds. Something that we do in hospice is that we do treat infections. So if we suspect a wound is infected, it's very important to, communicate that to your doctor and get an antibiotic going if necessary, because sometimes that will add a layer of healing to the wound as well. If it's infected, it's not going to heal. Where we're looking at comfort more so than aggressive treatment in hospice, like I said, we certainly love to see a good wound healed. We love to see them close up when it's possible. It is so rewarding to do wound care and watch a wound get smaller until it closes. Rolled edges, those are your enemy. That's where your wound is kind of rolling in and it's never going to close because the skin's not going to grow together. So something that a wound care nurse did teach me is, when you're cleaning, she said to rough up the edges a little bit with some gauze. That if you notice rolling starting, once it's rolled, we can't intervene like that. We can't. We can use enzymatic debriders. I haven't seen, I'm not going to be able to think of the name of it because I haven't used it in so long. We have enzymatic debriders, and that's a cream that you put on the wound and it will eat the tissue that's bad, but it can also eat the tissue that's good. So you got to be really sparing with it and make sure that you're going only in the wound bed and not getting on healthy tissue, because it will eat good tissue as well. With those things, some of your enzymatic debriders and some of your treatments, you need to know, how am I cleaning this wound? What can I put on it? What things interact with what things can't I use together? That is so important to know when you're doing wound care. It's also important, if you know someone that's good at wounds, reach out to them and ask them, what have you had success with? I've tried everything for this wound. Sometimes the doctors are not as experienced in healing wounds. That really isn't the area where they're strong in. Some doctors are amazing at wound care and they have good suggestions and they can give you good ideas. But it's always good to reach out to somebody who is certified in wound care management, someone who has experience with wounds, to help you and troubleshoot it and, brainstorm about it and talk to your doctor and see how they feel about, treatments. Sometimes a doctor will refer you to another doctor to ask those questions, because some doctors are more experienced in doing wound care and they would prefer to let somebody else do it, get somebody else to do it. No, not really like that. Maybe a little. But I think you just need to know, with some of those creams and ointments and products, they cannot be mixed together. With those enzymatic debriders, you need to be cleaning with normal saline or sterile water, you can't be using wound cleanser because it will interact negatively with an enzymatic debrider. With Dakin's solution, you can't be putting silver alginate in a wound. You can't be using alginates and Dakins together. They can interact adversely together. When you are experiencing, we use a lot of honey in wounds. That's a newer thing. I know there was a big thing where we were using silver gel all the time. That's still a good alternative if you can't get honey. Sometimes there's a shortage of those things. Where recently there was a big recall of important products and we had to figure out what we could use in its stead. Silver gel, silver hydrogel is really good to use for, mild debriding as well, and it kills the germs. There are things that we can do where the body creates its own environment. There's treatments that we can use where the body creates its own enzymes to debride. And the dressings that we have are made to stay on for several days, and they're most effective when they're undisturbed. So if you have a patient that is requiring daily wound dressings, I wouldn't recommend something like foam, because foam is really truly designed to stay on for up to 7 days. Rarely have I ever seen it stay on for 7 days, but that's what it's designed to do. And your alginates are really good if you have a lot of exudate, a lot of drainage in a wound, because they're going to help soak up some of that drainage and keep it, with alginate, you're going to make sure that it's to the wound bed, and we're going to fluff, don't stuff. So when we're packing something or we're putting something in a wound bed, we want to allow the skin cells to grow inside the wound. And I just can't be excited enough about wound care. I really do think that was an area that was something I was so passionate about for so many years, that it's still something you should know though. Once you have a break in the skin and it heals, it's still sometimes so fragile, and we only ever get 80% efficacy back to our skin. So that area is always going to be at risk to reopen and become a wound again. And that is something that you need to be aware of when you're doing wound care and those sorts of things, is maintaining that skin integrity once you do heal something. For heels, everybody loves the heel booties in that, but I'm going to tell you that if you put a pillow under the knees and at the edge of the heel where the heel is hanging off of the pillow, and you relieve that pressure, your heels are going to heal better when there's not pressure. And sometimes those booties and those special boots can create a new problem, especially in people that are compromised. Their nutrition's compromised, they're not hydrated, they're at end of life, and now you're putting pressure in a different area. Have you ever seen a wound in an Achilles tendon? It is so hard to heal wounds when they're in tendons or cartilage. And tendons are very fragile. We want to keep those moist because once they dry out, it's very difficult to get a tendon to be good if it goes bad. So make sure that you're thinking about that when you're thinking about what kind of devices or things that you're using to relieve pressure. Wedges are wonderful for turning and repositioning people that are not able to wiggle, but I'm just telling you, grandma and grandpa are going to wiggle their butt right into the position that they're comfortable in, even though they're breaking down and their butt's falling off. It's just the way it is. They're going to wiggle back down off of that wedge. So if you do that, you want to make sure that you're coming along the body, not just in one area. We want to give support to the back and the backs of the legs and the bottom, so that when we're rolling people over, they're in a stable position. And we want to make sure that we're putting pillows between knees, under arms, so that when our knees are together, when we're on our side, that the knees aren't rubbing together. Because there's bones in our knees that can rub together and break down too. So there's constantly needing to be movement when there's pressure. Another thing is, as nurses, as CNAs, as healthcare workers, we've had a tendency to pull somebody up in the bed, and that can cause shearing. This is where something is staying there and you're causing friction. You're causing a wound by doing that. So sometimes you'll see a wound in a weird place where the skin stayed and sat against the bone, and you wouldn't think that that would be an area where a pressure ulcer would happen. And then there's something called a Kennedy ulcer is what we call it. I don't know, they may have different names for it now. It was always called a Kennedy ulcer when I was younger, and in the Midwest is where I trained as a nurse and worked for most of my career. But that happens when a person is at end of life and things are shutting down. Your skin is an organ and it fails to. And sometimes those wounds are unavoidable. and they happen so fast that you didn't realize they were happening. You looked in the morning and there was nothing, and in the evening it was there. And that's that time window that I'm talking about. And this is so critical when somebody goes to an emergency room or something like that and they're laying on a gurney. If they're elderly, I know you're busy in an emergency room, but it's really important to try to relieve some of that pressure when you can. Help those grandmas out so they don't come back to us with bed sores. And also, if you have a person that's going to the hospital or going somewhere or coming home from the hospital, you want to look their skin over and make sure that you didn't miss a wound, because when you receive a patient or send a patient, you should always be doing a head-to-toe body assessment to look for wounds, and be sure that you're sharing that information with the provider that's taking over care, because people don't want to claim the wounds. And if they say it came to them as a wound and you didn't check that skin, you wouldn't know it's your wound. And the government's people that control things for us, that make the rules, will ding us for those sorts of things, just so you know. Anyway, I could talk about wounds forever. What are some wounds that you've dealt with, some challenges you have? What are some treatments you've had successes with? I would really love to pick your brains about this and talk about it in the comments, because it is something I'm so passionate about. So if you have any fresh ideas, if you have any interesting stories about wounds, I would love to hear about them in the comments. Please, please, please like, share, subscribe, follow if you're interested in what I talk about here. I'd love to talk more. I'd love to share more and continue to build a community of people who discuss it. I do have one interesting story. I had a gentleman years ago who had fallen and was laying in a position for several days. And my first experience was seeing inside of the leg, and my first experience with doing wound vacs was those many years ago because of that. And that was one of my most interesting wounds. So wound vacs are a whole other subject. We could talk about that another time. But thank you for watching, and I hope to see you soon. Bye bye.